As on the last in pediatrics, but today we are going to we'll see how we can make up because this month I'm on my annual leave, so at least if you will not be too tired, we can host up to like 2 or 3 sessions per week. Okay, so today we will talk about diabetic ketoacidosis, and like you suggested, I will just briefly differentiate between diabetic ketoacidosis and then HHS, hyperglycemic hyperosmotic state. So and then I will talk on diabetic ketoacidosis because that is really what concerns us in pediatrics. Okay, so I will use an introduction for diabetic ketoacidosis. Sorry, please. So I'll use an introduction. I'll do an introduction. I'll give you a brief pathophysiology of diabetes mellitus, and then I'll talk about the pathogenesis of diabetic ketoacidosis. Then some key things that is very important in diabetic ketoacidosis that everybody is afraid of is cerebral edema. So I'll talk about the mechanisms of development of cerebral edema, and then give some recommendations, and then I'll talk about the challenges in management of cerebral edema. After which we are going to talk about the precautions that should be taken when treating a patient with diabetic ketoacidosis, and then I'll conclude. However, before I go into that into the introduction, so permit me to say that diabetic ketoacidosis is mostly seen in children, and that is why it is so unique to us. Why the other one, hyperglycemic hyperosmolar state, is mostly seen in the older patients. We see it in children who have obesity, especially because obesity is one of the things that predisposes to that, to diabetic type 2 especially. So let me quickly just differentiate between type 1 and type 2 diabetes mellitus, because those are the two major. There are some other type of diabetes mellitus, but the one that we focus on are the type 1 and then the type 2. Now, the type 1 is commoner in children, while the type 2 is commoner in adolescents especially, and in adults. And in adolescents who are often obese, so you see more of type 2 diabetes in them. So there's a difference between the two of them, and I'm going to be showing you in earnest. So now let's look at this this slide. Can you all see this slide? So now look at this slide. Okay. I also hope that you can see my cursor. Okay, let me confirm that. Okay, yes. Now look at the healthy pancreas. You can see the pancreas, you can see the duodenum, the second part of the duodenum, and then you see the pancreas. You can see occupying that C shape of the second part of the duodenum. So that's where the pancreas is located. Now, what happens is this: when you eat food, there is increased glycemic level in plasma after every feed. Now, that increased glycemic level is being sensed by some what we call insulin sensitive cells of the body, and then they stimulate the production of insulin. Not only that, the high level of glucose in the blood also inhibits glucagon. So when the level of glucagon in the blood drops, the production of insulin is stimulated. Now, with the production of insulin, there is something that is called lock and key hypothesis regarding insulin production and glucose metabolism. Insulin serves as, look at this diagram here now. This blue is insulin. You can see this other one, this is glucose. What does insulin does? When insulin is produced, insulin comes to bind to the insulin receptor. Once insulin binds successfully to the insulin receptor, the door opens. That is the door of the cells, open, so that glucose can enter into the cells. Can you see glucose now coming to enter into the cells? Why? Because insulin was produced and insulin binds to the insulin receptor. And then glucose is now able to be mobilized from the plasma into the insulin sensitive cells. Now, when this occurs, that is a normal physiological response to the food that you eat. Look at about 3 things here: insulin, glucose, insulin receptor. Sorry. Now, what happens in type 1 diabetes? In type 1 diabetes, there is no insulin because of pancreatic failure. Usually, type 1 diabetes is usually caused by what we call autoantibody destruction of the pancreas, especially the islet cells of the pancreas. So now, when the islet cells have been destroyed to the point that up to 90% of the islet cells have been destroyed, it is at that point that you are going to notice that there is type 1 diabetes. So a child who is growing up might not exhibit the symptoms and signs of diabetes. Why? Because the cells, the remaining cells, still continue to compensate. They keep producing insulin until the point where up to 90% of insulin producing cells, that is the beta cells of the pancreas, when they have been destroyed up to 90%, that is when you start seeing the symptoms and the signs of diabetes. Now, what happens there? Now look at it. There is no insulin. And like I told you earlier, insulin serves as a lock to the cells. So the door is there, the receptor is there, but the only problem is that there is no insulin that will bind to the receptor. Since there is no insulin to bind to the receptor, the door of the cells remain locked. So glucose accumulates in plasma. Glucose cannot enter into the cells. This is what happened in type 1 diabetes. The problem is not with the receptor. The problem is not with glucose. The problem is not with the cells. The problem is with insulin production. There is no insulin. I hope this is clear. Now, that is what happened in type 1 diabetes. So now, in type 2 diabetes, what happened? The problem also is not with insulin. The pancreas is producing insulin. But what happened? There is a problem with the cells at the cellular level. The cell that has receptor to accept to key with the insulin so that insulin can open the lock. Look at the lock here. So you can see glucose has come to bind to the door, but the door cannot open because there is a problem with the receptor. So the problem in type 2 diabetes is at the receptor level, the cell receptor. Sorry, please, let me check this something. Let me get a laser. Okay, so I hope you're able to get it better now. So we're talking about type 2 diabetes. So now the problem in type 2 diabetes is what I've just explained. There is insulin. In type 2, the beta cells, that is the islet cells of Langerhans, produces insulin. And there is enough glucose in the blood. Because there's enough glucose in the blood, but there's a problem with the receptor, the cell receptor, the tissue receptor, so that insulin cannot bind normally to the receptor. Because insulin cannot bind to the receptor, there is now what we call insulin resistance. What meaning that the cells are resistant to insulin. So such that even though there is so much glucose around the door that wants to enter the cells, there is no key. There is no key to open the door. So there is accumulation of glucose in the blood. You can see type 1 and type 2 occurs through two different mechanisms. But the problem is, in type 1, there is no insulin at all because of the auto-antibody-mediated destruction of the pancreas. Why in type 2, the problem is that there is insulin production, but the cells are resistant to insulin. I hope this is clear. So while still on this slide, so let me talk about what happened in hyperosmolar hyperglycemic state. In hyperosmolar hyperglycemic state, this often occurs in very sick hospitalized patients, especially in the elderly. So for them, the problem is that there is also resistance to insulin, but for them, it is not as severe as what happens in type 2. So what happens is that there is reduced response to insulin because of some underlying illness. It could be an infection, it could be those who have stroke, it could be any of those conditions so eventually these patients cannot mobilize they cannot mobilize glucose into the cells. Because they cannot mobilize glucose into the cells, glucose now accumulates in the plasma. So this accumulation of glucose in the plasma causes the hyperglycemic state. And remember, when we talk about plasma osmolality, we talked about that glucose is a major contributor to plasma osmolality. So because of that, there is increased osmolality such that in hyperosmolar hyperglycemic state, the level of glucose can be as high as 600 milligrams per day. That's over 30 millimole per liter. So and the osmolality can be even higher than 320 milliosmol. Remember, the normal osmolality, the plasma osmolality is between 285 to 295. But now in hyperosmotic state, you can get as high as 320. So even greater. And then in them, the insulin in the blood, though it is not sufficient, it is sufficient enough to prevent ketogenesis place, such that there is very little or ketone in the urine. But most of the time there is no ketonemia. You will not ketone in the blood because the insulin is still sufficient enough to inhibit the breakdown of ketone bodies, that is lipolysis, the breakdown of fats. So all of this make it easy for make it easy for what I want to say, that it makes it difficult for the production of ketone, unlike what we see in the diabetic ketoacidosis. So background in place, the symptoms and signs of DKA, that is diabetic ketoacidosis, and hyperosmolar hyperglycemic state, they overlap. But the difference is that we rarely see HHS in children. It's mostly seen in adults, and that is why I was telling you we will not put so much focus on it, because both of them still have similar method of management. The same method we use in managing diabetic ketoacidosis, we still adopt it in management of hyperosmolar hyperosmolar hyperglycemic state. The only difference is that the level of dehydration in HHS is far more than that of DKA, such that it's very easy for a patient with HHS to die, because they also have a form of blunting to their thirst receptor, even though they are supposed to be thirsty and drink water because of dehydration, but because of the blunting to thirst, their receptors, the receptors are blunted to thirst. They cannot even know whether they are thirsty, whether they are dehydrated. So it's very easy for them to die from dehydration, especially from shock, hypotension, and all of that. So that being said, let us focus on what we want to do today. In the next few minutes, let us talk about diabetic ketoacidosis. So now, if you look at this table, you'll see some of what I've been talking about. We'll talk about the pathogenesis and the pathophysiology of diabetic ketoacidosis. Now look at the first box here. Just follow my my pointer. Now look at the first point here. There is reduction in insulin. Insulin level has dropped. When insulin level drops, what happens? What happens? There is increased production of the counter-regulatory hormones. And what are the counter-regulatory hormones? Please take note of them. These are questions that comes out in MCQ. We have cortisol, we have growth hormone, catecholamines, glucagon. These are the counter-regulatory hormones. All of these hormones that you see, they are the opposite of insulin. They work, they counter the function of insulin. Once insulin level is low, their level rises. Once insulin level is high, their level drops. So that is how it works. Now, what do they do? What do they do? Now, with the reduced level of insulin, remember I told you in the previous slide that insulin serves as a key to the door that opens for glucose to leave the plasma into the cells. So what happens? There is reduction in utilization of glucose. So glucose is so much in the blood, in the plasma, but glucose cannot be used by the cells. This is a typical example of what a cell, somebody is starving in the midst of abundance. There's a lot of glucose in the plasma, but the cells are starving. They cannot make use of the glucose. So what
Chief,
Chief,
this is similar to type 1 diabetes.
Yes, I'm talking about type 1 diabetes. This is what is happening in type 1 diabetes.
Okay, DKA. Okay.
Yes, DKA happens mostly in type 1 diabetes.
Okay.
Is that okay?
Why HHS? Why HHS is mostly in type 2?
HHS is commoner with type 2 diabetes.
Type 2, okay.
And it's commoner in older in adults. So that is why, because this is pediatrics, I am focusing on diabetic ketoacidosis. Because this is what we see is mostly in pediatric patients. Is that okay? Okay, so now this is what because of that reduction in insulin, there's reduction in utilization of glucose. And then when glucose is not being used, there is hyperglycemia in the plasma. So now let's continue. With reduction in insulin, what happens? The counter-regulatory hormones stimulate the process we call lipolysis. That is, lipolysis is the breaking down of lipids. There's lipolysis. So with lipolysis, what happens? There is production of free fatty acids from the production of free fatty acids. So when free fatty acids are being broken down, they lead to the formation of ketone bodies. Ketone bodies. Now, what are the ketone bodies that we have? We have the acetone. We have the butyric acid, and then we have the acetone. So the three of them, they form the ketone bodies that are produced from free fatty acid. The free fatty acid are produced from lipolysis. So the end result of that one is that there will be ketoacidosis. Remember, all those ketone bodies, like the butyric acid now is an acid. So that gives the ketoacidosis that result from DKA. So now that is in the part of lipolysis, in the part of lipolysis because of reduction in insulin production. So please take note of this slide very well. These are some of the things that we used to confuse in MCQ. When insulin level is low, what will happen? There will be increased lipolysis, there will be increased free fatty acid production, there will be increased ketosis. Now what happened? By the time the fats have been broken down, and then there is still no enough glucose in the cells. Remember, there is enough glucose in the plasma, but there is no enough glucose in the cells. So the end result is that the body will start breaking down the protein. So there will be breakdown of protein by a process called proteolysis. So now, when that happens, there will be reduction in protein synthesis. So protein will not be synthesized. So the overall thing that happens in decay is that there is catabolism. Catabolism, that is breaking down of things. Now, that is what happens when there is no insulin. When there is insulin, there is anabolism. So insulin production results in anabolic state. Why? Lack of insulin results in catabolic state. So get that one very clearly too. So when that happens, there will be increased gluconeogenesis. If you remember your physiology or something like that, it's called that glucogenesis is the production of glucose from non-carbohydrate sources, from free fatty acid, glucose can be produced. From protein, glucose can be produced. Do you understand? So when all of this happens, the reason the body is doing all of this is to make sure that there is enough glucose in the plasma so that the cells can get the glucose. But remember, it has become like a negative feedback mechanism that has been caught at one point, because normally when the plasma glucose level rises, insulin is pumped into the blood to bring down that level, But now insulin is not available. So the cells will keep communicating to the communicating that I'm hungry, I'm starving. And because of that, there will be now stimulation of every apparatus, every mechanism in the body to make sure that more glucose is pumped into the circulation so that the cells can get it. But we now discover that the problem is not with the cells, the problem is not with the receptor, the problem is that there is no key, and that key is insulin. So look at another process is what we call increased glycogenolysis. Increased glycogenolysis, meaning that the glucose that has been stored in the liver, we have to be broken down also back to glucose so that glucose can be mobilized into the plasma. So all of this will result to hyperglycemia. Now let's look at it. What happens now with hyperglycemia? With hyperglycemia, what are the things you have? You have glucose in the urine. Glucose in the urine. Now, there's what they call threshold for glucosuria. Glucose in the urine is called glucosuria. It has a threshold. When the level of plasma glucose is more than 180 milligram per dl. Let me take it again. If the level of plasma glucose is greater than or equal to 180 milligram per dl, that is 18 millimole per liter, you start seeing glucose in the urine. But any level beyond that, the kidney has the capacity to reabsorb all the glucose that is filtered through through glomerular filtration. But once the plasma level of glucose is above 180 milligram per dl, at that level you will start seeing glucose in the urine, and that gives what we call glucosuria. And remember, glucose is an osmotically active agent. Because of that, glucose draws water with itself, such that as glucose is being lost in urine, a lot of water is also being lost. That is what gives the symptoms of polyuria. So the polyuria here is due to the osmotic diuresis that glucose is causing. Yeah. And when there is polyuria and patient is losing fluid, that patient will start getting thirsty. Yeah. We want to drink water, and that process is what we call polydipsia. Now, remember we told you that glucose is being broken down, and yet the body still needs glucose. So, and then the proteins are being broken down, yet the body still needs more glucose. Then the body will start breaking down the fats. That is what happens, that the patient now will be eating more than usual. The patient will be eating too much, and that excessive eating is what we call polyphagia. Now, I've talked about polyuria, polydipsia, polyphagia. Now, in type 1 diabetes, in DKE, another information you will get is that despite the fact that the patient is having polyphagia, the patient is still losing weight. So there is loss of weight despite adequate feeding. The patient is eating, even overeating, yet the patient is losing weight. These are some of the things that we help you to differentiate that this thing is likely type 1 diabetes. Unlike in type 2, a patient who has type 2 diabetes will be overweight or obese. But the one that has type 1 diabetes will be losing weight despite adequate feeding. So can you get the difference between them now? So remember also we talk about ketone. By the time ketone bodies are being formed, then there is ketone in urine. The moment you are able to see glucose in the urine and you see ketone in urine, you can diagnose diabetic ketoacidosis. However, standard definition is that there should be ketonemia. Ketonemia, that is, ketone is found in the plasma. It's not supposed to be found normally, but when it is found and you see hyperglycemia, then you can say that there is what is it called? Diabetic ketoacidosis. I hope that is clear.
So, Doc, Chief, ketones should be present, the glucose should be present, the hyperglycemia.
Yes, hyperglycemia. Yes,
hyperglycemia.
Yes. So now, what are the triad of diabetic ketoacidosis? The triad of diabetic ketoacidosis, there is hyperglycemia, there is acidemia, and there is ketonemia. I hope you take note of that. Hypoglycemia, acidemia, and
where's
then
the acidemia? The acid is the acidemia.
Acidemia. You can diagnose acidemia with low bicarbonate level. That is acidosis. Just telling you that there is the blood is acidic. pH of the blood is less than 7.35. So the blood is acidic. So all of that diagnosis diabetic ketoacidosis. I hope this is clear. Hyperglycemia, acidemia, and then ketonemia. Hope it's clear. So let me not bug you with this. I will put up another slide now so that we can talk more about all of this.
So the previous slide, the first one you just after the triad.
Is it this?
Okay, thank you.
Okay, I don't want to go into this yet, so I will put up another slide now.
Okay.
So I hope you understand what I've explained so far, Abi.
Yes, thank you.
Please, 1 minute. Okay, so I will go to the clinical features now. What are those clinical features that the patient might present with, those who have diabetic ketoacidosis? So let me put up this slide now. Okay, have you seen the slide? Okay, so now some of those symptoms include weight loss. Remember, I told you weight loss despite adequate appetite. That is very, very important. Then ketones. Now, with ketones in the blood, the patient may be nausea, vomiting, abdominal pain. Sometimes they present with altered level of consciousness or even in frank coma from hyperglycemia. So then they can present with shock because of hypovolemia. Then dehydration. The dehydration could be mild, could be moderate, could be severe. So now other symptoms, the abdominal pain. Now some of these things can be mistaken for other illness. For instance, now the patient can just present with abdominal pain. That is why in a most emergency point, the normal routine test is random blood sugar. So the moment you get a random blood sugar that is above normal, above 11.1 millimole per liter, that is more than 200 millimole per liter, milligram per DL, you diagnose there is hyperglycemia. The next thing you want to do is that you want to collect the patient's urine to check the urine for.
Please come again with that, please. The hyperglycemia
Okay,
diagnosis.
hyperglycemia. Okay, let me see whether there's a slide where I define that. Okay, so it's there. Okay, so let me just give you that definition so that you get it once and for all. Look at it. Hyperglycemia is blood glucose greater than 11 millimole per liter or 200 milligram per DL. Is that taken?
Yeah.
Now look at the definition of ketonemia. Ketonemia is when the level of ketone in the blood is greater than 3 millimole per liter, or when the level in the urine is greater than 5 millimole per liter. Is that taken? What is acidosis? Acidosis is when the venous pH is less than 7.35, or when the bicarbonate level is less than 15 millimole per liter. Acidosis. I hope this is clear.
Yes, sir.
Okay, now look at other definition. Okay, so let me not bug you with this one. Come in, please. Okay, this is not what I want to show you. Okay, so let's go. I think that has been taken, Abby.
Yes.
So let's go to the next one. And I've explained all of this pathogenesis and pathophysiology. So let's proceed. Okay, so now a patient might present with abdominal pain, and if you are not careful, if you are not careful to quickly check the blood sugar level, to quickly check the urine, you may think it's a surgical emergency, and you may be writing consult to the surgeon, not knowing that it is the ketonemia that is causing the abdominal pain. So it's very important. It requires what we call high index of suspicion for you to be able to diagnose it in a patient who just came and said, abdominal pain, my tummy. It could be diabetic ketoacidosis. Now, so some of them present with shortness of breath. They have difficulty with breathing. So, and that you may mistake that one for a primary respiratory distress. You may think it's pneumonia, not knowing that the patient is going into respiratory failure or because of diabetic ketoacidosis. Some of them present with what we call cosmal breathing. Cosmal breathing is a deep, shallow breathing. And when you see a patient who come like that, you may think that the patient have asthma. So you can see that all of this look like something, meaning that as a doctor, your head must be thinking very straight so that you'll be able to do some small investigations that we make you to make diagnosis of this. And when you make the diagnosis, you'll be saving the patient. The reason why you must know this. Now, another feature you may see is that the patient may be smelling ketone smell. By the time you perceive some smell, some fruity smell of ketone, some fruity smell of ketone from the patient's breathing, the patient will come with altered sensorium or come with frank coma. So all of these characterize the features of it. So what are other features that you can see? You can see features of dehydration, and I think we talked about this in one of our lectures. You can see all of those features of dehydration. Oh, my time is fast spent. Let me rush through so that I can talk about the management. So dry mouth, I don't need to talk about all of these features of dehydration. We already know them. So other things, you can also, the patient may be vomiting. There could be features of other illnesses because most of this thing is caused by an infection, or often stimulates a patient whose islet cells have been destroyed by antibodies all along, may still be coping. But the moment that patient had a little illness, it exacerbates the background or underlying condition. So malaria can stimulate it, urinary tract infection can stimulate it, respiratory tract infections, or even candidiasis, especially in females, can stimulate it. Other features you can see is that some non-specific malaria, the patient is just feeling unwell and just walk out. There is a set of DKA patients that we call walking DKA. They are walking up and down, but they can fall down and die at any time. We call them walking DKA. They are people who have diabetic ketoacidosis, but they are not having any symptom, no symptom at all. Some of them will just come with malaria, they just feeling general body on, they just feel unwell. And that is the reason why they come to the clinic. But it's not late for you as a doctor to help them make the diagnosis and prevent them from dying. So let's talk about the treatment. Now, what is the goal of therapy? What is the goal of therapy? There are principles that you follow. One, I think about 5, 6 principles. One is to correct dehydration. Two, correct acidosis and reverse ketogenesis. 3, restore blood glucose to near normal. 4, correct electrolyte imbalance. 5, avoid complications of therapy, which is one of it is cerebral edema. Then finally, identify and treat any precipitating event. That is, you treat any infection or whatever that has led to the illness. So now, don't forget also that diabetic ketoacidosis is an emergency. It's an emergency. Once you diagnose it, becomes an emergency. So you do an emergency assessment. How do you do an emergency assessment? Remember your ABC of resuscitation. You make sure that the airway is patent. If the patient is not saturating well, you give oxygen. So if you notice that the patient is very dehydrated, you only put up an IV intravenous cannula so that you can be able to give fluid. And while you are doing that, you are collecting blood sample, and then you are giving IV medications, and then you are monitoring the heart. So while you are doing all of those emergency assessments, remember to you take quick history. You take quick history to find out the cause, and then you weigh the child. Don't forget, in children, we deal with weight. Weight is very, very important. You weigh the child, and then you assess the degree of dehydration, assess the level of consciousness, and then also do biochemical assessment. That is why you collect all of those. Okay, someone is talking.
No, so Doc, I just wanted to find out, for example, as you mentioned earlier, a child comes to you with general body awareness, right? So where do you start from? Is it that you ask for the blood sample, the urine? Where do you start from to get DK diagnosis?
Okay, a patient who come to PUB and said, I'm feeling unwell.
Yes.
Then what you do is that there is what you call the heart of clacking. You have to learn the heart of clacking. So you must take history. So, and part of the things you ask for is this: those things, those symptoms and signs I've talked about. It's okay. Do you feel thirsty all the time? By the time you start asking those questions, yes, I used to feel thirsty and I urinate too much. By the time you hear something like that, what do you want to do next? You want to say, okay, have you lost weight recently? And you say, yes, I noticed that my trousers are beginning to get loose. The clothes that tied me before, it's now becoming loose on my body. Is it making sense gradually?
Yes.
By the time you get that history, what is the next thing you want to do? Say, okay, please, can we check your blood sugar level? Do you understand? And the next thing is that you check the blood sugar level, and then you are getting 25 millimole per liter. What is the next thing you want to do? You know, say you have already diagnosed hyperglycemia, isn't it?
Yes.
The next thing you want to say, okay, please, can you give me your urine? I want you to check your urine. And then you check the urine, and then you see ketone in urine. What diagnosis have you made?
DK.
You have made DKA.
Yeah, hyperglycemia.
Yeah. So you have made diagnosis of diabetic ketoacidosis. So with that, you can now progress. Does it make sense?
Yes, Doc. Thank you.
Okay. So now, when you've done that, by the time you collect blood samples, what are the things you are looking for? Remember, we talked about blood glucose. You also collect sample for serum electrolyte. What are the electrolytes you are looking for? You look for sodium, because for every milligram per DL rise in glucose level, the level of sodium drops. So glycemia often leads to hyponatremia. So you check the level of
Can you come again with that?
Okay, in very simple term,
yes.
Hyperglycemia, what you have is hyponatremia.
Okay. When there's increased glucose, there's decreased sodium.
There's decreased sodium. So that is one. Also, you check for potassium, because the level of potassium is usually low. They usually, okay, let me say, sorry, I say low. The level of potassium may be normal. Is because of the dehydration. Don't forget, with hyperglycemia, hyperosmolality, don't forget, I told you that time in one of our lectures, that there's going to be what we call cellular dehydration. The cells will be dehydrated.
Yes.
So what happened is that the potassium in the cells would have moved into the interstitium, into the ECF, such that by the time you check the serum level of potassium, it may look normal or even elevated, but it is factitious. It is not real, because the moment you start correction of your dehydration, the potassium will go back to where it is coming from, and the next thing is that there will be hypokalemia. So potassium is one of the things that you monitor when you are managing DKA. You always check for magnesium, because all of these are now. Other investigation you can do is what you call glycated hemoglobin, what you call hemoglobin A1C, hemoglobin A1C. It helps to tell you whether this hyperglycemia you are seeing is a recent thing or it has been there for more than 3 months. So it helps to diagnose chronic hyperglycemia. That is what hemoglobin A1C does. Then other things you do phenol pH. Remember we told you when the pH is less than 7.3, you said there is acidemia. You check for the partial pressure of CO2, hemoglobin level, full blood count, and all of this. So beta hydroxybutyric acid is one of the ketones that you check for in the serum. So when you see it, it also tells you that there is ketonemia. So what other things you do? Remember we talked about urine, you do urinalysis. So blood culture, urine culture, and all of this can let you know whether there is any infection that is causing the decay. Now look at it. The first thing is you correct dehydration. You correct dehydration. So I will rush through this. I don't know whether we still have time to discuss this. Now you correct dehydration. That's number one. So Chief, what do you do? What are Chief, your goals? Yes.
In correcting dehydration, what is it? Normal saline or?
I'm good. I want to talk about it now. I want to talk about it now.
Okay.
I want to talk about it now. There is something you. Okay, sorry. We'll talk about the risk of cerebral edema, and because when you correct too rapidly, the cells we absorb all of those fluids very rapidly, and then the cells will swell up, and then you see cerebral edema, and that can be very devastating. The mortality of cerebral edema is so high. The mortality from cerebral edema resulting from decay is so high. So that is why you don't want to correct too rapidly. So, but what you want to do also is that you don't want to correct too slowly too, because the patient can die at any time. So what do? There's what you call different phases. One is the quick phase.
Sadio.
Sorry, please let me share my screen. There was distraction. Establish that the patient. Okay, so like I was saying, I said when you have examined the patient, you have taken your history, and then you have established that the patient has diabetic ketoacidosis. Most times they come very, very dehydrated. So when you have diagnosed that there is severe dehydration, or the patient is in shock, or there is reduced peripheral circulation, what to do is that you have to give fluid very fast. You quickly give anti-shock. you give anti-shock. But the issue is that even when you are giving anti-shock, you remember the normal anti-shock is given at 20 mils per kg of normal saline, if you remember that, or Ringer's lactate. But in diabetic ketoacidosis, we still give over 1 hour, but at 10 mils per kg because of the risk of cerebral edema. We want to reduce that risk.
Okay.
And then
Doc, this
the second phase is
what are we using for the anti-shock, Doc? What are we using for
give? Okay, maybe you just calm down. Let's go through this, okay? So now, in the quick phase, you resuscitate with crystalloids, normal saline or Ringer's lactate. Those are the two fluids, normal saline or Ringer's lactate. But in most cases, normal saline is preferred. And you give at 10 mils per kg over 1 hour. So if you give after the first 1 hour, you check for the peripheral circulation. Is there improvement in circulation? If there is no improvement in circulation, you can repeat the second time, 10 mils per kg per hour. So now, when you have given that initial fluid over the first 1 hour, the next thing is that you have to now proceed to the slow phase. So, and when you are correcting the dehydration, you don't correct too rapidly over 4 to 6 hours, like we talk about in food and electrolyte management earlier. But you correct over 48 hours. You correct the dehydration in DKA over 48 hours. But remember that you have already used 1 hour to give resuscitation fluid. So subsequently, you will now give the remaining one over 47 hours. I hope that is clear. So now, sometimes IV access is not available. You search for line because the patient is dehydrated. You cannot get anything. So you can set intraosseous line. So intraosseous is that you put needle into the bone, and the most common site that you use is the proximal tibia. So just like about 2 centimeters below the tibia tuberosity, that is when you insert your needle, and then you put into the bone marrow, and you can resuscitate through that. So like we said earlier, you give at 10 mils per kg over 1 hour. You use normal saline or you use Ringer's lactate. Now, we'll talk about all of this. So now, what we'll do is that when you are giving your fluid, you keep giving normal saline or Ringer's lactate until glucose level drops below 15 millimole per liter. That is, if it drops below 250 milligram per DL. Once the level drops below 250 milligram per DL or drop below 15 millimole per liter, that is when you start adding dextrose containing fluid. I hope that is clear. Now, for the maintenance fluid, if you remember when we talk about correction of dehydration, we talk about the Olidesagase formula, whereby you give maintenance fluid. Are we still together? So when we talk about maintenance fluid, now for DKA, there is age-appropriate maintenance fluid. We do not follow that Olidesagase formula. Rather, we follow we use the age-appropriate fluid volume to give maintenance over 47 hours. So this body, however, the principle of correction is the same. You correct deficits, and then you give maintenance. Those two things goes together. So, like I said, you do it over 48 hours. Now, in standard books, they will say you should correct deficit at 7.5%, meaning that you give 75 mils per kg for deficits. 75 mils per kg. Remember, for severe dehydration in a normal patient who is not DKA, is 100 mils per kg. Do you remember that? But in DKA patient, you give at 75 mils per kg. But despite the standard, what is obtained in standard book, according to the American Diabetes Association, they have come with a table, which I will show you right now. Now, there's a table in which, based on the age, you will just use a particular volume. Look at that table now. For patients who are between the age of 0 to 2 years, you use 80 mils per kg as your maintenance fluid. 80 mils per kg a day. For those who are between the age of 3 to 5 years, you use 70 mils per kg. For those who are between 6 to 9 years, you give 60 mils per kg per day, and those who are between 10 to 40 years, you give them maintenance fluid at 50 mils per kg per day, and those who are above 15 years, they don't need as much fluid as those who are younger, so you give them at 30 mils per kg per day. The reason for this fluid restriction is that even though there is dehydration, you also do not want to teach the child into cerebral edema. I hope this is clear.
So I get to know, Doc. So that cerebral edema, is that central pontine myelinolysis?
Yes, it is. Yes. Cerebral edema will lead to that. Yeah.
Oh, okay.
Okay, so the next slide we're going to take an example. We're going to take an example, but before I show you the example, I want you to take your pen and your paper. We'll be using 1 minute to calculate this, and I'll see whether your value will be like now. So we have an 8-year-old child who is diagnosed DKA. 8-year-old DKA patient. The weight is 25 kg. And the patient is severely dehydrated. So calculate your resuscitation fluid, calculate your deficit, and calculate your maintenance. Let me know what your answers are. 1 minute. Dr. Isaac, I should be rounding up, Abi.
Yes, sir, you can.
Okay, so after this example, we are going to round up. So the resuscitation, remember we told you it is 10 mils per kg over the first 1 hour. Abi, so how many mils does that come to?
For what's his weight or age, please?
25 kg. The age is 8 years. 8 years, 25 kg, severely dehydrated. So how much food are you giving for the first 1 hour?
$100.
Why?
No, 1,000 mils. 1,000 mils.
Why?
Because for the first 10 kg, for his first 10 kg, it's 2,500, it seems. So it will be 10 times 25.
Okay, so obviously you don't get what. That's why I decided to bring up an example. Remember, I told you that resuscitation fluid is the fluid you give to expand the intravascular volume. That is the anti-shock. The anti-shock you give at 10 mils per kg over the first 1 hour. Then you now give deficit. Deficit you usually give at 75 mils per kg. I told you rather than giving full at 100 mils per kg for deficit, you give at 75 mils per kg. Because you are restricting fluid, you don't want to give too much. Why the third thing is that you give maintenance, daily maintenance. So for this patient who is 25 kg, what is his daily maintenance? And I noticed that you are confusing deficit with maintenance. It is maintenance in normal patients who are not DKA that you use the Oludesagase formula, where you will use the first 10 kg, second 10 kg, and the rest of that. But in DKA, we don't use that formula. There is a table. In fact, the table is the one on your screen right now. So this child is 8 years old. What is his own maintenance fluid?
60.
Daily maintenance will be what?
60 mils per kg per day.
60 mils per kg per day. That is his maintenance fluid per day.
Yes.
And the deficit will be what?
75 to be 75 mils per kg. So 75 times 60.
Yes. No, why don't you just say? You have to get this thing, though, because if you are doing this thing, you are saying the patient will just die in your front. So you have to get it. Now, understand, there is what you call anti-shock. Anti-shock.
Yes. Resuscitation fluid.
10 mils per kg. For a patient who is 25 kg, that is 10 times 25, isn't it?
Yes.
That gives us 250 mils. Abi?
Yes.
Now, the next one is the deficit. The deficit. The deficit is 75 mils per kg. Do you remember?
Yes.
So, and out of the 75 mils per kg, you have already used 10 mils per kg to give your anti-shock, isn't it? So, how much are you left with?
65.
You are left with 65. So, the remaining deficit is 65 mils per kg. So, 65 times the weight. What is the weight of the patient?
65 times 25.
So what did they come to? That's about 1,500, Abby.
1,625.
Okay.
1,625.
Okay, 1,625 meals. That is the deficit, isn't it?
Yes.
So for the patient who is 25 kg, what is the maintenance? What is the daily maintenance? That is 25 times what now?
The daily maintenance.
Yes.
Times
daily maintenance.
To be the weight is 25. Times 60.
Times 60. So that gives you 1,500 meals, Abi?
Yes.
So that is what you are. This is the fluid that you are going to give the child. Now remember that we say you correct over 48 hours, Abi? So, and out of the 48 hours, remember you have used 1 hour to resuscitate. So you are left with 47 hours. So you will now calculate for the second day. Remember what you calculated is daily maintenance. So that 1,500 meals, you now multiply by 2. That is 2 days. That becomes 3,000 meals. Abi?
Okay, for 2 days. For 2 days.
For
the
2
maintenance.
Days, that's 3,000 meals. Then that maintenance, you will now add this to your deficit. What was your deficit? Our deficit was 1,625 meals, Abi?
Yes.
So you will now say 1,625 meals plus 3,000 meals. Everything will give you what? 4,625 meals. So what you are giving the child over 47 hours is what? 4,625 meals. Is it clear?
Yes, Doc.
So if you are giving 4,625 meals in 47 hours, so let's cut it down now. How many meals will you give in 1 hour?
So we divide by 47.
Divide by 47. So what do you have? 4,625 divided by 47. What do you have?
98.4.
98.4. So you are giving this patient 98 meals of fluid every. Is it looking simple now?
Much better now. Much better now. So we start with resuscitation fluid, right?
Yes.
So it's 10 mils per kg, right?
Yeah.
So in this case now, that is 25 kg. So 10 times 25, 250 mils.
Yeah.
Over 1 hour, right?
Yeah.
For anti-shock, to improve circulation, to increase the lumen of the vessels, right?
Intravascular volume. To expand.
Intravascular volume.
Okay.
So then we'll go to deficit, right? At 75 mils per kg, right?
Yes.
So now that we already used 10, we already used 10. Now from the 75, we now have 65 remaining. So 65 times 75, we now have 1,625. Then for maintenance, the age group, we use the age group, not the oligosage formula. So we then have 60 for the age of 8. So multiply 60 by 25, you have 1,500 meals. Since it's over 2 days, we multiply the maintenance by 2.
Yes.
Okay. So then we'll now do deficit plus maintenance. We'll now add deficit plus maintenance.
Yes.
Okay.
And you now give it over 47
hours.
You now give it over 47 hours. Is that taken now? So to break it down to hourly, you now divide by 47. Abi?
Yes.
Okay, so that is it. So please just hold on 1 minute. So is it clear, please?
Yes, please.
Okay, I'm coming.
Doc, I can't hear you, please. Doc, I cannot hear you.
Okay, all right. I'm happy you got that, isn't it? So you can see when we correct it this way, it will be very easy for you to do, and then the patient gets better. Okay, so now remember that the fluid is, you still continue to use normal saline or gas lactate until the blood sugar drops below 15 millimole per liter or drops below 250 milligram per day. That is when you now introduce dextrose, that is glucose, into your fluid. Is that taken?
Okay.
Now, this on the other hand, that you'll be giving insulin. From the second hour, after you have given the anti-shock, from the second hour, you start giving insulin. Sorry, you start giving insulin infusion. So I will tell you now how to calculate insulin. Okay, let me go to one of the insulin therapy. So after this one, now we are going to call it a day. So insulin therapy. What does insulin does? Look at it. It blocks production of ketones. It stops production of glucose in the liver. You can see. It stops ketogenesis. It stops glycogenic uptake of glucose. Remember, we told you that insulin is acting as a lock, as a key to the cell that open the door. So when you give it, the glucose that is in the blood now will now be available to the cells to use, because insulin will go there and open the door for them to enter. And then it also now you start after the first hour, not within the first hour. And then you give insulin at 0.1 unit per kg per hour. You give insulin at 0.1 unit per kg per hour. That is how to calculate it. Now, sorry please for some background noise. So now the next thing we are going to do now is that we are going to calculate insulin. How to give insulin. Remember, I told you that fluid is going on one hand, insulin infusion is running on the other hand. So now for a patient whose weight is 25 kg, how much insulin will the patient needs per hour?
0.1 times 25.
Yes, which will give you what?
2.5 or 0.25?
Yes, 2.5.
2.5, yes.
2.5 units per hour, Abi?
Yes.
So if you want to calculate how much insulin the patient needs to take per day, you now multiply by what number? By 24, Abi?
Yes.
That gives you the insulin per day. But remember, we have calculated our fluid, and we said we are giving fluid at 98 mils per hour, Abi?
Yes.
So the same way, you are now giving fluid. You are giving insulin at 2.5 units per hour. So every 1 hour, you give 2.5 units of insulin. In case they bring it out in MCQ and they just ask you how much insulin will you give per hour, you just calculate. You know that 0.1 unit per kg per hour. I hope that is clear. Yes, and then as the patient is getting fluid in one hand, is getting insulin in the other hand. I think I'm going to stop here. I hope that we have opportunity to continue from here next time. So, or should we take an example before you go?
An example, please. An example.
Okay. I just hope that this example will not give so much confusion for you. So, our patient is 8 years old. And the weight is 25 kg. So, how much of insulin are you going to give this patient?
So, okay, 8 years old. Should be 2.5 units per hour. So we're going to do 0.1 times 25.
Yes, it's just as simple as that. Okay. So now the other things will not be okay, because it is from that your fluid that you now take the fluid you use for the insulin. But all of those ones, by the time you pass and then you come over to the hospital, we will sit you down, and then because that one is more practical than exam stuff. Okay. So by that time you are going to learn, because you are the one who will do all of these things. But for the first time, the person who is your registrar or your senior registrar will sit you down
and teach you.
The fluid and everything you are going to prepare together, but you are the one that will be doing the monitoring. So now when you have a patient with DKA, you need to monitor this patient. What are the things you monitor? You'll be doing serum electrolyte every 6 hours, so that you can see whether the potassium is dropping or not. And then you also checking the urinalysis to see whether the ketone is reducing or not. You also check for glucose, whether the glucose in the urine is reducing or not. You check for serum bicarbonate to see whether the acidosis is resolving as you are hydrating the patient or not. Then you also check for the level of consciousness, because when you start fluid and you notice that the patient is becoming more unconscious, what has happened? Can somebody guess?
Cerebral edema.
Yeah, cerebral edema is setting in. So those are the things you monitor. Is your patient getting more awake, or is getting more drowsy or dizzy? So that tells you that likely you have been too aggressive with your fluid, and you need to calm down. So, I know so far we have been able to establish.
Thank you very much, Chief. My question is on that first arm where we're giving the fluid, right? Either normal like lactate. After that, then you mentioned giving dextrose, glucose. Why? Is it to drive it into the cells?
Because remember you are giving insulin through the other
insulin on the down that will drive it, that will drive them into the cells.
So if you don't start insulin infusion, you will teach the patient towards hypoglycemia. You know, hypoglycemia is even more worrisome than hyperglycemia.
Yes, hypoglycemia.
So you don't, because the glucose level is now going down, insulin is now available. At no distant time, the patient can go into hypoglycemia. So that is why once you notice that the blood sugar level has dropped to below 50 millimole per liter, you start glucose containing fluid, and then you continue your insulin normally. Because as you are giving the fluid that contains glucose, insulin is mobilizing that glucose into the cells, and it is neutralized.
Yes.
So I believe you have learned something. So we have been able to talk about the diagnosis of how to diagnose diabetics. We talk about the different types, type 1 and type 2. We talk about the pathophysiology. We talk about the normal state. We talk about the disease state, the pathology. So we talk about the symptoms and signs of diabetic ketoacidosis. We talk about the investigations you can do when you are seeing a patient with diabetic ketoacidosis. Then we talk about, basically today we have talked about how you can correct the dehydration over 48 hours, and also how you can use insulin therapy from the second hour of your correction. So I hope that this goes on well with you, and that you will not forget so soon. I wish you so much success in your exam.
Thank you very much.
Do have a wonderful evening. Or is there any question?
No, I think I'm okay. Thank you very much. The Olisesage spelling. Can I hear that Olisesage spelling?
Olisesage is HO double L.
Okay.
IDAY.
Okay.
Then Sage is SAGAY.
Okay, thank you very much.
I hope I get the spelling too.
Thank you.